Yay, Media Group.
So often a number doesn't tell us the full story. That's the case often with total cholesterol. We know that total cholesterol can be totally misleading at times. Even something like LDL or our bad cholesterol, the LDL number doesn't give us the full picture of what's actually happening inside of our bodies, what's actually representing our risk factor for cardiovascular disease. So in today's episode, we're joined by expert cardiologists to walk us through how to interpret our lab numbers, that LDL, what are other tests to ask for, and then how do we address it? How do we approach it? Is it medication? Is it nutritional supplements? We're breaking down all of this data for y'all in this week's episode of Fueled Wellness and Nutrition. A quick note before we dive into today's podcast. If you like what you hear, I would love for you to subscribe to Fueled Wellness and Nutrition, wherever you download your podcast. It would also be incredible if you take a minute to rate and review this podcast. Those things do matter and they really help us.
I'm Molly Kimball. Welcome to Fueled, a wellness and nutrition podcast. I'm a registered dietitian and nutrition journalist with a passion to help people live their strongest, healthiest life possible. In my weekly TV segments and columns, there's a limited amount of time and space to cover everything, but there's so much more to share. This podcast is my opportunity to dive deeper into the topics you want to know about.
This episode of Fueled Wellness and Nutrition, it's really driven by a personal experience that I had, and it is about cholesterol, and it's about LDL cholesterol. But the catalyst for this was my own experience. And so as a dietitian for decades, I eat, I would say really healthfully, exercise, movement, maintain a healthy weight, all of these things that don't match what my LDL, my bad cholesterol was showing. So over the past few years, past probably 8 years, it has continued to increase. And so normal, you would want your LDL or your bad cholesterol under is about 100 for most people. And it had been that years ago, but for about the past 10 years, it was creeping up to 120, then 130s, and then hovering in the 140s. And now it's been in the 160s for several years. And so it was something that I really wanted to address this, and I made nutritional changes. I added certain supplements and nothing seemed to budget. So in this episode, we're sitting down with Dr. Lavie, and he's walking us through in your lipid panel that you'll receive. What does it look like? What are the optimal levels for things like our total cholesterol, LDL, HDL, triglycerides, your standard panel that you're going to get, how to interpret that. But then beyond that, if you're like me and that LDL, that bad cholesterol is elevated, that doesn't mean right away, oops, we've got to take a medication. It doesn't mean that just because you have a high LDL, it's time for a statin drug. There's a lot of other information beyond that LDL number. So what we'll be talking about in today's episode, we cover a lot. This episode is over an hour long. So we're going to be talking a lot about, how to interpret these lipid panel results. What I think a lot of y'all are going to be interested in is, what is that deeper dive? How can we understand our risk factors beyond LDL, beyond just that number? And Dr. Lavie is covering with us what are some of the key diagnostic tests that give a deeper understanding to our cardiovascular risk factors. So beyond LDL, you've got your LDL, you see it's higher. What are other diagnostic tests, other labs that we can do that can help to give us a deeper understanding about our cardiovascular risk factors? So with that, I think let's dive in. Welcome, Dr. Lavie.
Great to be with you tonight.
Share with us a bit to your bio and your expertise. I don't even want to try, because how many papers do you have published now?
I have probably close to 1,700 papers, but PubMed has 1,253 listed today.
What are they doing? Slackers, huh? So 1,700 papers published, peer-reviewed journals. You've been with Ochsner as a cardiologist for how long now?
35 years.
Right. Well, the data, the numbers, the science, I think that what I really appreciate is your ability you're so immersed in that world of the science and the data, and you have such a good way of communicating it in an easy to understand, relatable way. And so I thank you for that. The today's episode is really, sort of a personal catalyst for this. And so for our listeners, when we're talking about LDL, often again referred to as the bad cholesterol, this is something that over the past couple of years, really the past 5 years, my own cholesterol has continued to go up, which doesn't worry me so much. And Dr. Lavie and I will talk about total cholesterol versus the different types, but my LDL had continued to increase. And, we'll talk about what the normal, optimal levels are, but it had gone from about, the hundreds for most of my adult life, 1 to 120, started creeping into the 130s. And gosh, for the past 4+ years, it's been in the 155 range to 160s. And as it started to approach the 160s and then stay in there, that's when I started to get concerned. And my primary care physician, Dr. Kenny Cole, he kind of looked at the same thing. Like, at what point do we need to say, okay, this is getting high? But it wasn't just okay, Molly's LDL is in the 160s, so let's go straight to statins. There was a lot more that we explored, and Dr. Cole and I also looped you into the conversation. And so one of our questions was, what are some of the other things we want to look at to assess risk factors?
Yeah, so the reason why there's such a focus on the LDL is because that's where we have therapies, particularly the medications that can effectively lower the LDL. LDL is actually, even from the lipid standpoint, not the strongest risk factor. We have other stronger risk factors. But the reason that LDL gets the attention, and that's why it's probably the focus of the lipid guidelines, is because we have the best therapies to do something about that. Not only do we have therapies that really effectively lower the LDL, but they're therapies that are proven to be safe and to reduce clinical events. And so that doesn't mean, though, that everyone that has a little bit elevated LDL necessarily needs to be on particularly prescription medications, because it depends on what their risk is. Obviously, it would always, for every single person, it would be better to have a lower LDL than a higher LDL. But some people could have an LDL that's 110, and their risk is way higher than somebody who has an LDL of 170, depending on the rest of their risk factors.
So talk to us about what the normal levels are before we get into the other things to look at beyond LDL. So when we're looking at kind of the key components, you mentioned total cholesterol, the HDL, LDL, triglycerides, and then, as you said, kind of the non-HDL cholesterol. Let's walk through the optimal ranges for each. If someone's kind of thinking through, so this is the part that if you're listening and you're going to compare it to your own labs, take notes.
Yeah, so for total cholesterol is a mixture of good and bad. So there's not really an optimal total cholesterol. Generally, somebody who has a 300 total cholesterol, their profile is going to be bad. Somebody who's under 200, their profile is usually going to be good. But because total cholesterol is a mixture of good and bad, it's really a number that it would be better not to focus on. The HDL, you like to be, in general, the higher the better. We consider less than 40 to be low, and less than 50 to be kind of low for women.
And that not being a good thing, because higher is better.
Yeah, because you'd like to have higher. And generally considered HDLs above 60 are considered high, which is usually very protective. Now, we do know now with HDL that there is data around the world that suggests that as you go super high for HDL, you might lose the protective effect. And so that means that many people who have HDLs in the hundreds. Many of them have lazy HDLs that are not very active, taking, in something that's called reverse cholesterol transport, which the HDL takes cholesterol away from the arterial walls back to the liver for metabolism. And so some people with very high HDLs have an inactive HDL, and they're not being protected by the high HDL. And part of that is also around the world. One group of people, for example, that have very high HDLs are heavy alcoholics. Some people who are drinking a fifth of vodka a day, for instance, in Russia, they can have HDLs very high, and they're not healthy for other reasons. And so despite their very high HDL, they have premature mortality.
So to kind of restate it, the HDL, the reason we would consider it being protective is it sort of goes through and is pulling and clearing and helping to clear the cholesterol from the bloodstream and helping to
it's not cleared necessarily from the bloodstream, but taking it away from the arterial walls where it's getting stuck in the arteries back to for example, the liver for metabolism and excretion. So keeping the cholesterol out of the bad places, which is particularly the artery walls, preventing it from clogging up the arteries.
So HDL being like your cholesterol broom or sweeper.
Scavenger.
And then if you are a person who has really high HDL and you've been sort of, thinking you're golden with that, too bad if you've got lazy HDL. Who knew that was a thing? But to where it's not effective. It's not doing the job in the same way.
And that's particularly when HDLs are over like a 90 and 100.
Interesting.
So up to around 80 HDLs are really, generally pretty protective. And if you get to super high, and every now and then you have somebody with 150 HDL, and that certainly might be at the level where you've lost the protective effect of the HDL.
There's sort of that misconception about the 200 mark. It's really more about the composition of it. The high HDL is protective up to a limit, up to a certain point, and then walk us through the others as far as the optimal ranges.
So triglycerides is a fat in the blood that's probably not received the attention. It's actually very high triglycerides is bad from a number of reasons, but really there haven't been as well proven therapies for triglycerides. Certainly values for triglycerides, a really good value would be having it below 100. Usually above 150 is considered borderline, above 200 is considered mildly high, and above 500 is considered very high. And at very, very high levels, particularly like in the thousands, not only is there may be some risk of atherosclerosis, but there's a big risk of pancreatitis, which is a pretty serious condition that in some people. And so for triglycerides, you'd like it to be as low as possible, and a really good thing to prevent very high triglycerides is keeping simple sugars, carbohydrates lower, and avoiding high alcohol, which is good for triglycerides. Now, the LDL, which is the bad cholesterol, generally we consider optimal LDLs as below 100. Now, in people who have blocked arteries, now we're trying to get some people's LDLs to, if they, say somebody has a calcium score of 1,000, we might be trying to get the LDL under 70. If somebody's just had a big heart attack and a stent, many times we're trying to get their LDL down to the 50s. So even though we consider 100 optimal, we know that getting even lower LDLs is even better. But for the LDL, the bad cholesterol, generally 100 to 129 is considered borderline. Above 130 is considered mild high. Where you are a lot of the time. Above 160 is considered moderate high, and above 190 is considered severely high. And our guidelines say everyone above 190 should be on a medication for their LDL cholesterol. Now, saying that, what if somebody had an LDL, let's say a 70-year-old lady had an LDL of 195, but her HDL was 80, and she's 75 years old and she just had a calcium score and it's a perfect 0. Does she really need to be on a medication? And, that would be, so there's guidelines, but the guidelines are for generality. That doesn't mean they apply to every single individual. Certainly in the world, most people who have LDLs in the 190s need to be on medicines. And many people who have much lower LDLs need to be on medications or some therapies for their LDL. But that's where you need to individualize, because there's many other ways that we can assess risk of the individual, and it's not just all LDL cholesterol.
So when we look at LDL, ideally in the general population, ideally under 100, and that 100 to 129 being considered a healthy range. Mine, as we said, had been in the 130s for years. Above the 160s is considered moderately high, and that's where mine had been hovering for the past couple of years. And so that's why it makes sense when you say the 190 or above. My primary care physician, Dr. Cole, said, prepare yourself that if and when your LDL makes its way up into the 90s, that we need to consider a statin. And that's sort of when, for me, the alarms went off, because I thought it was in the 100s to 120s, then 130s, now 160s. Why am I going to just sit around and wait for it to keep going up? Let's look and see, like, what is risk? What's my risk factors? What are all these other things? It also makes a lot of sense because, my dad had such significant blockage. Fortunately, he didn't have a heart attack. He had stents before. And now his cardiologist, his LDL's in the 70s, but they're even going up on his statin to bring it even a little bit lower because of exactly what you said. So that 100 doesn't really apply to him because of the other risk that he has. Under 70 is even better.
So probably in your dad's case, most cardiologists would want to get his LDL under 70, and some would make the case he probably wouldn't fall into the very high risk group. If they're a very high risk group, we're trying to get it under 55.
Wow.
And so some people say, well, if you're trying to get some people under 55, why wouldn't you take somebody who's got the stent? And again, your dad's, I forgot his age now, but I think it's probably upper 70s or low 80s. So I think that if he gets his LDL below 70, and he's not had big clinical events before. He had a stable coronary disease and got a stent for it. But anyway, I think some people would say, well, why not try to get him down to 52? I think that many people would be very happy with him just being under 70.
Right.
But still, there's no harm in getting it even lower,
right?
Except for sometimes it takes more medications to do that,
right? Which is what they're doing. So as we had the conversation with my primary care, you and I kind of, okay, at what point should we be concerned? We did a deeper dive and we went beyond that LDL and we said, okay, let's look beyond LDL to fully assess my cardiovascular risk. And while I'm using myself as the example in this, I think there's a lot of people listening to this who their cholesterol might be elevated, their total, but that LDL might be also. And so this is the part that I want y'all to hear of what are the other things to explore to look at that risk, and getting Dr. Lavie's take on what are the other types of tests to talk with your provider about. Exploring this for yourself.
It's the simple things that we already know about the individual already tell us a lot about their risk.
Right.
But then we can do other things to further assess the risk. And some of these other things are, for example, a coronary calcium scan. That's a test that we typically start doing that test in men at close to age 50, and women, but maybe in the 50s or maybe even close to 55. And the reason why we don't do it at super young ages is because many people can even have atherosclerosis at young ages, and it's not calcified yet. So your score could come out to be perfect 0, but you already have a lot of soft plaque. And then the other thing is that the calcium scan has got a small cost to it. Not very expensive. Ashna right now charges $125 for it, but again, it's still a small cost. And then it also has radiation. So it's not a lot of radiation, but it's an X-ray. And so if you're going to do an X-ray on someone, you want to make sure that it's something that's going to really help you impact them. And so a perfect calcium score is 0. And I have many people in my practice that have scores of 5,000. They have tons of plaque. And sometimes when you get a person that and just for example, in a 50-year-old woman who doesn't have a perfect risk profile, let's say her cholesterol is quite high. Well, if we did the calcium score and her score came out 300, which would be a super high score for a 50-year-old woman, that you'd want to treat very aggressively. Whereas if you had a perfect score of 0, you could still say a 50-year-old woman should have a score of 0. You probably want to do it again in 8 years or something to see if it's going to remain good. But if it's score 0, at least you know that you probably don't have to be as aggressive. There's other things we can do. A really particularly other thing is lipoprotein(a). That's one thing that I'm recommending now. Every adult should get one time because it's genetically determined. And we're finding there's a lot of people, and a very high Lp(a) value carries about the same risk as having diabetes and being a smoker.
Wow.
So the normal LP(a) in our lab goes up to 30, and our lab uses milligram per deciliter, and there's other labs that have a little bit different number scale. So our lab goes up to 30, and if they use a different kind of assessment, the normal goes up to 75. But if you, in our lab, if we have people that have scores of 70, 80, 100, and I have people that have scores in the many hundreds, this is genetically determined and they're at very high risk. We're trying to develop, the field is trying to develop therapies for LP(a), but right now, the main therapy for LP(a) is to try to work on the other risk factors like LDL.
And you said that an elevated lipoprotein (a), an elevated LP(a) carries the same risk as diabetes and
smoking.
Yeah,
so it's a very, very strong independent risk factor.
And that's not something that's typically done. So that's something that most people would need to request.
So people are starting to do it, but I would still say most people in our society, even those who are regularly seeing physicians, many have not ever had the LP(a) assessed. And many primary care clinicians have not implemented in their practice. Not all cardiologists have been routinely doing it.
And so the calcium score is one, ideally as close to zero as possible, the LP(a), and then particle size.
Yeah, so particle size is something that most people don't recommend. And I don't routinely do that. Now, if somebody does a particle size, you'd like your particles to be you'd like you not to have a high amount of small, dense LDL particles because those are more atherogenic. The problem is though that there's been no big studies showing that changing that or intervention directed at that changes the risk. We know that if you find out you have a very high small particles, your risk is higher. So it doesn't hurt you to know that. It's just that exactly what would you do and what would your clinician do? I guess you could say what they do is try to treat you a little bit more vigorously.
I think of it, I kind of have the visual of the small, dense particles could collect and compress easier than the big fluffies.
Yeah.
That's sort of my visual for it.
That is true. The thing is, though, that there's no national society that recommends testing for particles.
Got it.
Now, some people do it, and I think most people, don't do it. But some people that have, certain types of practices will check everybody, do a particle test on anyone, and some people will do it on people who request it. Like I said, the guidelines don't say to do it, and no national society, whether the National Lipid Organization, the cardiology societies, the diabetes societies, none are recommending particle size. Now, I don't have a problem if somebody does it. The issue is what someone's going to do with the results.
Right.
And so right now, I think that that there are other things that would be more important to do, and you get most of the information from the simplest stuff.
And what about the apolipoproteins A and B?
So apolipoprotein B is the protein which coats all what's called the atherogenic particles. It coats the LDL, the VLDL, which carries it's called very low density lipoprotein that carries the triglycerides, and intermediate density lipoprotein, which is something that's not measured. So ApoB is actually correlates more with clinical events than does LDL. The therapy, though, is all aimed at LDL.
Right.
And there's a very good correlation between the non-HDL, which is just taking the total cholesterol minus HDL, and ApoB. Now, ApoB is a little bit better than non-HDL, but it's very, very highly correlated. And so the issue would be, like, for example, the Diabetes Association recommends doing an ApoB. The cardiology has not. Most of the societies have not. Again, I have no problem with doing an ApoB, but I think generally we know what the ApoB is going to come out by just a simple lipid profile. And the ApoA is just a protein that coats HDL, and I don't think that adds a lot.
So as we were having the conversation,
So the thing that I'm not sorry to cut you off,
good.
Molly, but the thing that really changed is totally different. So we get most of the information from the total cholesterol, HDL, triglyceride, and then calculating the LDL. The thing that we don't have any idea of. So even from that, we would be able to very well predict the particles, the ApoB, the ApoA. We have no idea about the Lp(a). Lp(a) is totally different, and so that's something that would really add to risk assessment. And I think that many of the societies now are starting to talk about. No society has mandated everybody to get an Lp(a), but I think that, and I do think that's coming, especially when and if the therapies that are being done for very high Lp(a) are shown to be safe, and they have already been shown to be safe, but if they're shown to have significant clinical event reduction, and I'm predicting that they're going to have pretty significant clinical event reduction.
So someone gets their lipid panel back, they see, oh wow, my LDL is high, but like you said, you're seeing your total, you're seeing your LDL, your HDL, your triglycerides, your non-HDL cholesterol, which you can, just subtracting the HDL from your total. So if there's going to be one thing that someone is going to kind of press for a little bit more information on, it would be the lipoprotein(a).
I think that lipoprotein(a) would be the one additional thing that I would recommend everyone to get it once as an adult. You don't need to do it over and over because it doesn't usually change much over time. It's genetically determined, but it's a risk factor. The other thing would be, for many people, not everyone has to do this, but many people would be helped, at least at above the age of 50, and especially in the mid 50s towards 60, of getting a calcium scan.
Calcium score. Okay.
That would be very, very helpful, because sometimes you can have two people that have fairly similar risk profiles, and one of them could have a calcium score of 0 and the other one could have a 300.
Well, as we were having this conversation back and forth, Dr. Cole said, okay, with your LDL being in the high 160s, he said at one point, if your calcium score is anything but 0, I want to really consider a treatment. And I was grateful when it came back at 0.
Yeah. And again, I think, it's very good that it was 0, but honestly, Molly, it should have been 0, because you were less than 50, and we don't usually do it too often in women in their upper 40s. And so a bad score would have been really bad.
Right.
So if your score would have been 50, even though that's not a super high score, that would have been a super high score for a 48, 49-year-old woman. And so, and there'd be a lot of men in their 50s and 60s that would love to have a 50 calcium score. But still, it was comforting. But I think that, if you got it done later and it was still 0,
even better.
That's even better, because you really probably at your age, 75% of women or 80% of women would probably have a 0.
So I'm going to say it again for our listeners, just because I know that there's a lot of words and kind of content that we're talking through. So as you do, when you have your cholesterol checked and you have your lipid panel that you're getting back, and the great thing now is so much of it is in the electronic medical records. You can click and see. You can easily. My dad was showing me his on his phone, and you can see trends over time. Your normal lipid panel is going to show a lot of information with your total, your LDL, your HDL, your triglycerides. If from that you say, you know what, I have elevated LDL, the bad cholesterol, another piece of information that's not included in that, we're not going to have that picture from this, is the lipoprotein(a), and this is the one that is genetically determined. And so it's really, really a crapshoot of what that's going to come back as. And then the other, in addition to that, would be the calcium score. Those are the two that Dr. Lavie is saying, if you're going to ask for something extra, or look for more detail, more data to base any decisions off of, these are two requests. Beyond that, if we look at particle size, or we're looking at the apolipoproteins A and B, those are interesting, but not really a game changer in data. So speaking of the risk and looking at the different risk calculators, I saw one online. It was one that Harvard had as part of their I'll put the link to it in the episode notes. Are there certain tools that you recommend for the lay person to use to understand their cardiovascular risk?
So the thing that's recommended is the atherosclerotic cardiovascular disease risk calculator, and that puts in that's the one that most clinicians and most studies use, and it has the total cholesterol, the HDL, the diabetes status, the hypertension status, the smoking status. It doesn't have everything. For example, it doesn't have weight in it. It doesn't have family history in the calculator. It doesn't have couple of fancy things. So you can improve. It doesn't have even exercise and fitness, which are very important predictors of risk. But that's the standard thing that most clinicians use to assess the 10-year risk, and it is pretty accurate. It's you can improve on that. And again, I don't know if the Harvard one you just mentioned has better things in it than that, but there's been many giant studies that have used the atherosclerosis cardiovascular risk calculator, and you can go online and put your numbers in that.
I'll pull it. I'll link to both also there.
Yeah, and that's what the American Heart Association, the ACC, that's what all the lipid guidelines use. That's what the hypertension guidelines use to assess risk, because that's considered the kind of the gold standard.
So when we're looking at, okay, well, these are all the things to give you the background of how do we interpret your lipid panel, your lipid profile? What are some of the things, the markers that we can talk to our provider about to give us that even more detailed picture? The lipoprotein little a, the calcium score. So then we get to the point where, like me, okay, my LDL's in the 160s. It's continued to stay here, and it's actually hasn't continued to stay there. It's on the upswing. What am I going to do to improve LDL? As I understand it, there's kind of three main approaches: nutrition or diet. There's potential supplements that we can talk through, and then there's medications, which is often going to be statins, as we're talking about LDL. Anything that I'm missing? Diet, supplements, medication, those are sort of the main.
No, that would be the main thing. And obviously, if someone's diet is terrible, they can change their LDL a lot by going to a very much better diet, by reducing the saturated fats and cholesterol in the diet, particularly probably the saturated fats more than cholesterol. But if someone's diet is not perfect, if they just improve it a little bit, they're going to drop their LDL a little bit, but not going to make big changes. So many people, so it would always be better to be with a healthier diet, not just for your LDL, but for whole other things, cancer,
mood, anxiety,
cancer risk,
everything. Right.
And so I'm all for everyone, making a diet as good as it possibly can be. It's just that if a person's diet is not that bad, so somebody who's eating McDonald's and fries, every day, if they go from that to eating a really healthy diet, they can improve their profile a lot. It's just that if people are eating a decent diet, and it's not perfect, but it's decent, and then they make it a little bit better, they're going to improve their risk profile a little bit, like maybe drop their LDL by 5 to 10 points, but not by 50 points.
As I was seeing mine, steadily on the rise from the 100s, 120s, it was probably when it was in the high 130s. I thought, okay, well, as a dietitian, lots of fish, very little red meat. My primary source of animal saturated fat is coffee with the half and half in there. So I thought, okay, let me do all plant-based versions of this. And everything that I could do that was an animal saturated fat, I found a plant-based alternative. And I did that for, 6 weeks to 2 months, rechecked it. It was the same or even a smidge higher. And I'm like, and I wasn't liking my coffee as much. I was missing, some of the real things. And so when I went back to just the real half and half of my coffee, same. I mean, it didn't seem to affect it either way. And as a dietitian and looking objectively at my nutritional intake, there really wasn't a room that things like a sprinkle of real Parmigiano Reggiano, the amount that you're getting in that is such a small bit. And so it was things like that I would look at. And Brad, of course, kind of became one of those husbands that was like, are you sure that you've got high cholesterol? Is that good? And I'm like, all right, like we're not going to get into this conversation, this circular conversation, because objectively I was like, there's not something nutritionally that I'm doing that's driving this up. So then my next look was, okay, I don't want to just continue to sit here and watch it go up into those 190s that are going to be the concern. So then that leaves me, okay, we'll take nutrition out of it. It leaves me with the option of supplements or prescription medication. And we'll talk a lot about supplements coming up, but I want to talk about the prescription medication typically is going to be statins. And, you know, you and I have talked about this a lot. There's a tremendous track record of safety when it comes to statins. And I'll say I'm aware of that and I hear it and I'm aware of it. Personally, though, anytime that I can do something that I feel is a more natural approach versus a prescription medication, I want to at least give it a try. And that was sort of my reason for going the supplement route, which we'll talk next. But talk to us a little bit, you know, the track record of safety when there's just no question that statins are going to be recommended. I guess a little bit on that.
I think certainly this is not 100%, but I think that the majority of physicians believe statins are like wonder drugs. There certainly are people that absolutely will get muscle aches on statins, but when you do studies of 1,000 people on statin versus 1,000 people on placebo, which was done for all of the statins decades ago, the muscle aches are reported to be exactly the same in the placebo and the statin group. And that doesn't mean that there can't be an occasional person that really gets, but many people will blame their problems on the medicine.
It sort of also has just that reputation for that, you know, people have that fears of it. And so they're expecting that. And so it wasn't specifically that, but just kind of with most of the things that I try, I think let me try an alternative approach first. And so I talked with Dr. Cole, my primary care doc. I said, hey, you know, this is in the 160s. And I know that you said when it gets to the 190s, then, you know, the alarms start to go off even more, but I don't want to just wait for that. So I want to give it a try with the red yeast rice extract. And so red yeast rice extract structurally it's chemically identical to a statin.
Very similar to lovastatin, which was the first statin, I think, that came on our market in 1986.
And for that reason, it's not something to, I don't want to say take lightly, but it's, you know, a lot of times if we're looking at certain supplements, we would say, oh, like, you know, if it's an omega-3 or a multivitamin or a B vitamin, there's a lot that we would just say, for the most people, just take it. There's not anything to even have a pause about it. But red yeast rice is not one of those. It's something to take it with some caution.
Yeah. So especially if someone really needs a lot of cholesterol lowering, they have to take pretty high doses. The typical dose is up to 3,600 milligram a day of red yeast rice. And you can get liver test abnormalities from that. The problem is that red yeast rice, unlike statins, are not regulated.
Right.
So it's a food source. It's not prescription. And so it doesn't have the same quality control. So, you know, which red yeast rice brand do you get? And again, I certainly wouldn't know which red yeast rice brand to tell someone to get, but probably they're not all created equal.
You're right.
Probably all omega-3 is not equal. Now, I do think, like you said, I don't think there's any dangerous omega-3 products out there. There's some are purer than others, but for red yeast rice, there's probably big differences in the quality. And the problem is when it's not regulated, you're not even sure the same company is going to be given the same quality in every batch.
And so any kind of nutritional supplement for our listeners, nutritional supplements unfortunately aren't regulated. And so, you know, just if you're going to get your B vitamins, there's no governing body that's going in and checking these like there is with the pharmaceutical industry. So as Dr. Lavie is saying, if you're getting a statin, that is highly regulated. Any nutritional supplement out there is not. And so it becomes a trust factor for the brand that's producing it. And we're relying on the brand. It's almost like the burden of proof is on the brands and the companies that are producing these. I'm going to put into the show notes of this, there's I really like the website consumerlab.com. It's a paid website. You do have to have it. It's a subscription-based website. But what I like is that they independently test brands. And so they test brands of product of, is there a level of contamination? Does it contain what they say is in it? Does it contain anything that they're not disclosing is in it? What is the concentration of the active ingredient? And so they have narrowed it down to a few recommended brands, and I'll put those in our episode notes.
I do think red yeast rice is very safe. I just think that would be
There's
something
a caution.
that one, you shouldn't go to 3,600 milligrams is 3,600 milligrams is the maximum dose. If you did 10,000 milligrams, it might have toxicity.
Right.
Also, it's probably worth an occasional blood test, when you're taking something like that.
So when I started it, the lowest dose recommended is usually 1,200. So 1,200, 2,400, or 3,600 being kind of the norm. So I thought, well, if 1,200 is the lowest dose, I'm even going to go half that, 600. And it dropped it into about the low 140s. And I was happy about that. That was only in 6 weeks. And then it kind of hovered there for like the next 6 weeks. So I said, well, let me up it to 1,200. So 3,600 being the upper limit. I started at 600. Then I brought it to 1,200. And 12 weeks later, I'm in the low 130s. And I was happy about that. I'm like, this is really trending in the right way. I don't feel the need to go up any. And we're also keeping an eye on the liver enzymes, checking. And so I think if you did want to consider something like a red yeast rice extract, let your physician know. And this is something that, having this very open conversation with your provider to say, hey, I want to give this a try, because you want their support and helping make sure that you're doing this safely. And then also, is it even working? So for me, seeing what is it doing to my LDL and how are my liver enzymes doing? So keeping an eye on those things.
And then Molly, if there was really a need for you to get a much lower LDL, your dose could be higher.
Right, right. There's room for it.
There'd be nothing wrong with it being 2,400 or 3,600 milligram per day. Now, certainly, you could say, would it have been okay for you to have just left it at the 160? And again, it's always better to be lower, and you feel better about it being lower.
I feel better about it because I felt like I was going to just be so passive, and then all of a sudden it's going to be in the 190s, and what the heck, So I thought, let me try to be proactive now, especially looking at my dad. I know that, he's 84 now, and I thought, but still knowing that, I thought, why be so passive when I feel nutritionally and exercise wise and all of these other things, all these things are in place, yet it keeps rising. So red yeast rice is one that I've been really pleased with the result. I think it can be an option for someone who, for whatever their personal reasons are, if there's a reason that they are looking for an alternative to a prescription medication like a statin. Red yeast rice is something to talk with your provider about, knowing that you also want to make sure you're checking for those liver enzymes and you're getting your lipid levels checked often enough to know, is this even working?
And Molly, I have many people taking red yeast rice, and the majority of the patients that I have that are taking red yeast rice are ones that really need to be on a statin, but are refusing to be on a statin. And I try to get them on as much red yeast rice as I can get them to take. And
is it dropping it?
Yeah, and typically 3,600 milligrams will drop it 25%, maybe even 30%.
Which is significant, yeah.
We had a low dose of many of the statins lower it by 35, 40%, and the high doses will lower it by 60%. But
Thank you for being patient with those of us who don't want to take it. Two others that I think are worth mentioning. One is psyllium. Psyllium being just a really great source of soluble fiber. Here's the thing, like 10 grams of soluble fiber a day. So we talked about the reduction in LDL that you'll see something with like red yeast rice might be the percent drop might translate to about an average of maybe 40 points in someone's LDL. The psyllium, what I'm seeing is that 10 grams a day of the soluble fiber may drop it by like 13, 15 points.
I think typically a good dose of soluble fiber typically will drop it by 5 to 10%. So that might be that
Yeah.
same. Your points might be correct, and again, it's a very healthy thing. I mean, it's good for the GI system. It's good for the bowels. It's good to prevent weight gain.
But let me tell you, getting 10 grams of soluble fiber a day, I felt horrible. So in that time that I was trying to everything, like what can I do to lower my own LDL? I said, let me follow my own advice and let me add 10 grams of soluble fiber a day, which is about 3 heaping spoonfuls of something like psyllium. Psyllium is Psyllium. The P is silent there. It's what's in like Metamucil, but you can also just get powdered psyllium. And so about 3 heaping teaspoons gives you the 10 grams of soluble fiber. Dr. Lavie, for decades, I've recommended this to people. Then I thought, well, let me just stir this into a little bit of water. It became like cement. I could hardly get it through a straw. It was horrible. And I thought, I want to call every single person that I ever said, and they complained. And I said, just do it. It's not for the faint of heart. And I think blending it into a smoothie is a little bit better. But things like capsules, I mean, you might have to take 15 or so capsules to get that amount of fiber. There's also these like gummy fiber, psyllium chews, insignificant amounts there. That 10 grams of soluble fiber, I also want to point out, that's about 5 bowls of Cheerios. So when someone says, I'm going to get soluble fiber, I'm going to eat Cheerios or oats, you got to eat a lot of that too. So the 10 grams of soluble fiber, you can get it, but you got to really work to get that.
And remember that it's soluble. So any kind of fiber is good for the GI tract,
right? But
you need the soluble fiber to drop the cholesterol.
Phytosterols. Tell me about your approach with this. Benecol is where we first saw it years ago on the market.
Yeah, so I think so you certainly can get a little bit of LDL reduction with that. There has been some negative publicity and some studies actually, some suggesting some actually pro-atherogenic effects of the sterols, and so I don't think they typically routinely recommend it. I don't have a problem with somebody doing it, but I think that wouldn't be my first approach to emphasize that. I think that the psyllium is very safe and doable and trying to reduce your saturated fat in the diet. That wasn't a problem for you, but for many people, they're going to get some LDL lowering by lowering the terrible foods they're eating and reducing the quantity of that. Where once your diet is already extremely good, making it even better isn't going to change things very much.
What about niacin?
So first of all, the only niacin that improves cholesterol is nicotinic acid. So it's nicotinic acid. There are many other niacins that don't have any effect on cholesterol, and some they'll even have some advertised in the drugstore saying this is a flush-free niacin. It's niacinamide, and it has no cholesterol lowering effects. So it's only nicotinic acid. And nicotinic acid does, lower cholesterol, and it's probably one of the better things that it actually raises HDL cholesterol, and it's one of the few things that right now that lower LP(a). Nicotinic acid. Now you got to use pretty high doses. Nicotinic acid gets you at 2 and 3 grams per day. That's a lot of nicotinic acid. But 2 to 3 grams per day can get you something like a 20%, 25% reduction in your LP(a). The only other thing we have right now that routinely lowers LP(a) is estrogen. And obviously men have a hard time taking much estrogen. And many women, could get some benefits from estrogen. That's another topic. Estrogen's a controversial topic. I personally think that many clinicians were scared off on estrogen because of a bad study years ago, the Women's Health Initiative, that basically used horse urine form of estrogen, and now at lower doses of estrogen, more natural estrogen. Estrogen can be, I think, safe for many women, particularly if they take it close to the time of menopause and don't start taking it when they're 75 years old, and don't use high doses, et cetera. But estrogen lowers LP(a) values and raises HDL values in women. And part of the reason why estrogen actually lowers LDL too. And so many women's cholesterol starts rising in midlife.
And so with going back to the nicotinic acid, is that something that you recommend, or
So
it sounded like there's a hesitation?
I think so. Right now, I think that there were studies done years ago with nicotinic acid and very high cholesterol that showed some clinical event reduction. I think most of the studies in recent years have not shown much significant clinical effects of nicotinic acid was particularly being used for low HDL. And there was a big study called AIM High, and it didn't have any clinical event reduction and had some toxicity. With nicotinic acid has a bunch of side effects. Flushing is a big one. It can affect the liver enzymes. I do think many people can get around the flushing effect and can tolerate the flushing. That's not serious. And the liver toxicity, you can monitor the liver enzymes. So I think I have no problem with somebody taking nicotinic acid. It's a good natural way to improve your lipid profile. And particularly, it's got to be nicotinic acid, not just another form of niacin.
So that's also a big one of talk with your provider, look at your risk benefit.
I think that somebody first of all, if you take nicotinic acid to treat your cholesterol, you're probably going to have to use decent doses. Like you can use 100 milligrams or 50 milligrams of nicotinic acid, and that's not going to change things much. The doses for treating the lipids would be more like 1,000, 500, 1,000, 2,000, 3,000 milligram per day, and that's when nicotinic acid is working as a pharmaceutical agent.
Okay.
It's an over-the-counter, non-prescription,
right.
And there actually is prescription forms of nicotinic acid as well.
And there's not prescription form of red yeast rice, right?
No,
I didn't think so. I was hoping that.
Well, in a way there is, because in a way that's what kind of lovastatin,
right.
which was the Mevacor, the
right.
first statin, and other statins would be kind of like prescription forms
right.
of red yeast rice. But it's not, red yeast rice is not exactly the same thing as lovastatin. It's very close to lovastatin, but it's not exactly the same thing. And
okay.
So it is a more natural form. And like I said, I think that when many physicians, when they think of red yeast rice, they think it's basically just a weaker form of statin. But I think many people like the idea of that it's more natural,
right.
and it's more in the holistic approach,
right.
as opposed to using a prescription medication.
Right, which is a bit of how I feel. So to recap, if you haven't had your lipid profile done recently, get it done. Have your cholesterol levels checked, and a lot of times it'll just be referred to as a lipid panel. You may see that. When you get that, you're going to see your total cholesterol, your LDL, HDL, triglycerides. And so that's what Dr. Lavie's kind of hit on, optimal levels of all of those. If you're like me and you see that LDL is elevated, then you can kind of look at that in relation to, well, what is my triglycerides? Are those also elevated? You'll know about yourself probably if you have high blood pressure or diabetes, if you smoke, overweight, all of those other things. You can probably relatively easily assess those risk factors. And what's not going to be in part of that picture is those other key factors that Dr. Lavie talked about. The lipoprotein little a is one to ask your provider, explore that with a test. And that's that one-time test for most people. It's something that's genetically determined. The other is that calcium score. And really discussing these with your provider. So if you, first thing is get your labs done. If you haven't done it, if you've been putting it off, get it done. Having our head in the sand doesn't do anything, knowing where we are, knowing our numbers, knowing where we stand, and getting them done at least every few years so that you can see what the trend is. So for me, getting them done every few years, I was seeing they were just trending up. And so, keeping that awareness up, working with your provider, doing some of those extra labs to give you the additional insight beyond LDL. And then from there, seeing what's your risk factors, what is your risk for a cardiovascular event. And in some cases, a statin might be really strongly recommended, and others, maybe you can try that natural approach with something like the red yeast rice. If if you're even just kind of starting with the baby steps, looking and evaluating the diet, what can we do on those animal-based saturated fats, especially? Let's tuck in some omega-3s, omega-3 rich fish or supplements, and then get that psyllium in, start stirring that soluble fiber into things. Lots here to cover, and I'm going to include the links that we talked about in the show notes. But I really appreciate your time, Dr. Lavie.
Well, thanks. It's been a pleasure talking with you tonight, Molly.
Always tremendously grateful to Dr. Lavie for sharing his time, his expertise with us, taking the science, the data, and really distilling it down to actionable guidance for us, helping us to filter through what's worth it, what's worth putting our focus into, and giving us alternatives. Here's the recommendation, and for someone who's looking for something more natural, these things are other options to consider. I'll include the links that we talked about in the show notes of this episode. So the recommended products for the red yeast rice, also the additional tests that Dr. Lavie talked about to give us insight beyond LDL, and the risk calculators. As you hear this, as you learn from it, if it's impacted conversations you're having with your providers, if there's other insight that it's giving you, we always want to hear about it. I am registered dietitian Molly Kimball, and you've been listening to Fueled Wellness and Nutrition, the podcast. If you like more Fueled Wellness and Nutrition, please head over to mollykimball.com, and you can follow me, Molly Kimball RD, on Instagram, Facebook, and Twitter. If you haven't yet, please go to Apple Podcasts and subscribe, rate, and review this podcast. Join us next time for another dose of Fueled Wellness and Nutrition. Thanks for listening, and stay focused on living your strongest, healthiest life.
Shop the Sherwin-Williams 4th of July sale and get 30% off paints and stains June 26th through July 6th. Whether you're refreshing your interior or exterior, we've got the colors to bring your vision to life. And with delivery, getting everything to your door is easier than ever. Shop online to have it delivered or visit your neighborhood Sherwin-Williams store. Click the banner to learn more. Retail sales only. Some exclusions apply. See store for details. Delivery available on qualifying orders.
I'm here on the job site with Dale, who's a framing contractor.
Hey, good morning.
Dale traded up to Geico Commercial Auto Insurance for all his business vehicles. We're here where he needs us most.
Yep, they sure are.
We make it easy for him to save on all his insurance needs, all in one place, with coverage that fits his business and bottom line. Oh, I shouldn't have looked down.
It's all right.
We're so far up here.
Look at me. Take a deep breath.
No, I'm good. So good.
Get a commercial auto insurance quote today at geico.com and see how much you could save. It feels good to Geico.